We've talked about PARP inhibition. Where do you see this, and what's the basis for our use of these PARP inhibitors in prostate cancer?
So there have been a number of exciting trials that have recently released data for the use of PARP inhibitors in castrate-resistant disease. The PROfound trial took those patients with DNA repair mutations, stratified them based upon BRCA versus other types of DNA repair mutations, randomized patients to receive olaparib or dealer's choice treatment, which could have included anything from abiraterone to chemotherapy. And they found that there was an improvement or a significant difference in radiographic progression-free survival, as well as objective response rate in favor of those patients who received the PARP inhibitors. So it's very, very exciting that we've been able to select patients with a different molecular mutation and then administer a drug based upon that mutation.
So TOPARP, I think, was the predecessor trial.
Correct.
This is not a big population of patients, though.
It's about 20% of all castrate-resistant prostate cancer patients. About 10% of all patients have BRCA1 or BRCA2.
Yeah. And you have to do germline on these, or can you do it on somatic?
You can do it on somatic as well as germline.
Yeah. But I believe that PROfound didn't allow cell-free DNA, or I thought they required somatic, didn't they?
They required somatic.
Or was it germline? I can't remember.
It was tissue. It was tissue that they used.
Okay.
The difference with other studies where they're actually using the liquid biopsy test to look for these particular mutations, Triton-2 and Triton-3, which are using rucaparib rather than using olaparib. Triton-2 is a phase 2 trial which has about a 50% response rate in those patients who have BRCA mutations. Triton-3 is a randomized study that would, of course, confirm the results from Triton-2, but these are a little bit more broad in their use of the molecular markers.
So I believe we also have a GALAHAD trial.
GALAHAD trial,
that's
right.
coming, and that's another PARP inhibitor, right?
Exactly.
That has not reported out yet.
That's not reported out yet, correct.
All right, so we're going to be dealing in this coming year probably with at least 2, maybe 3 PARP inhibitors.
Exactly.
And you're, again, if you're testing early on in all patients, and if you don't find a BRCA, or you don't find a DNA repair deficiency, would you retest your patients?
I do actually. I do retest, again, because this could be a clonal evolution of something that may not be picked up in the original test. What I'm also excited about are drugs that are trying to induce BRCAness. And I think that this is going to be the next step in this particular pathway. So as we said, only about 20% of patients have this mutation, but then how can we induce the cell to downregulate their DNA repair pathway such that you are sensitive to a PARP inhibitor? And this is where the combination trials are starting to come into play. Abiraterone downregulates DNA repair enzymes. Hypoxia will do the same thing as well. So at the ASCO GU meeting, we saw some other further abstracts looking at the combination of abiraterone plus olaparib. A randomized phase 2 trial showed an improvement in radiographic progression-free survival. And the interesting thing was it was irrespective of your BRCAness. And I think that was a very, very interesting little aside to this particular hypothesis. Joe Kim at my institution has looked at olaparib combined with a drug called cediranib, which is also an anti-angiogenesis agent. He demonstrated a 7-month improvement in radiographic progression-free survival in favor of the combination. Now, we haven't yet examined the different molecular markers. That analysis is underway. What I thought was particularly intriguing about this case was one of my patients, who actually happens to be a physician, is BRCA2 positive. He was initially randomized to the olaparib-only arm. He had about a 6-month response and then progressed. And the trial allowed for crossovers. He went on olaparib cediranib, he responded again. So this is, again, a very interesting little observation. And perhaps now we have to start looking at these combinations. The third combination, which I'm excited about, is the combination of PARP plus immune checkpoint inhibitors. There is a synergy between the two. And Dr. Karzai from the National Cancer Institute a couple of years ago presented some data of a PARP inhibitor combined with a checkpoint, and also saw the same pattern that you did not need to have a DNA repair mutation to have a response. So these are ways that we can potentially expand the applicability of these PARP inhibitors to our patients.